Hello. Has it been good? Or are you all just here to win a laptop? I'm going to win it. I filled in about 1,000 things at lunchtime when you were all eating. I am going to talk about NCT's take on it, but actually NCT is just a microcosm of the world that you all work in. So you all know, to a large extent, much more about the world that you work in. So kind of looking for a little bit of audience participation, that if I'm talking rubbish, shake your head. If you're agreeing, nod at me, because this is all work in progress. So I'm going to talk to you a little bit about a systems approach, and the systems approach that NCT is trying to take to sort some of this. Loosely structured around why do we need to change, what are we going to change, and more importantly, how do we change? Everybody is talking about integration, but nobody's quite telling us how to do it. And we think we might have a way forward. So very briefly, a quick canter through the current reality that we're all living in. We know that breastfeeding is one of the most effective ways of reducing health inequalities. We know it's not always easy, psychologically, emotionally, intellectually, physically. It's not always easy. We know that mother-to-mother support is declining. We also know from the Bolling research, 3 in 4 women start. Within 6 weeks, 4 in 10 of them have stopped. Clearly, integration isn't working for these women, not all of them. We also know that the woman's community, and by community I don't necessarily mean the locality she works in, but the integrated systems that support her, is how we would define community, is a significant determinant of her success. NICE will tell us, David will be here in a minute to nod at me sagely, that they recommend, as do UNICEF, a multifaceted approach or a coordinated programme of interventions across different settings. Hurrah! Don't think any of us would disagree with that. We need to integrate. So, what do we mean by integration? Now, I'm not giving you a lesson on integration. I've given you the reference there of what this diagram's from, and there's an excellent 2010-2011 King's Fund report talking about integration. It's a slide set with notes. It's brilliant. What I've put this slide up for is, when we say integration, are we talking about health with health? So are we talking about vertically in a hospital system? Are we talking about health with health, the shift into community care? Are we talking about health with social care, local government, third sector, local voluntary action groups? What actually do we mean? It gets quite complicated very, very quickly. Anybody Morecambe and Wise fan? Christmas specials? This is where you nod. Big fan in my family. And Eric Morecambe, this is Grieg. He's playing Grieg's piano concerto, very famous conductor, forgotten his name. And Eric Morton's, sorry? That's right, it's Andre Preview, you're absolutely right. And I'm not going to sing it for you, but very complicated, lovely piece of music, and Eric Morecambe pretty much plays 2-fingered chopsticks. And Andre Previn really can't understand what's going on, and the bit underneath my much too difficult box picture, I had another picture. It's where Eric Morecambe leans underneath the piano and he says, "Now listen, sunshine, I'm playing all the right notes, just not necessarily in the right order." And that's kind of where we are with integration. It becomes very easy to, I can't change it. I can't change all of you, but I can change my little bit. So I'm going to put all of your bits in my too difficult box, and I'll just make my bit as bright and shiny as I can. And then we have 4 in 10 women giving up breastfeeding in the first 6 weeks. So clearly it's not working. My microcosm. This is just to give you an example of the microcosm that is NCT. To tell you on a national basis, when I try and convert what NCT does nationally into a particular local community, the chaos that I find. So, what I know is in blue, we have a booking in appointment. We know not all women book in at the right time, but at some point they book in. And for most women, there is a labour and there's a birth. In green is what you would know and expect to know about NCT. We have 317 branches, and they do stuff. Whole variety of stuff. Good stuff. We then have from head office, which is where I'm based, we then have the yellow bits, which is our universal provision that everybody can access free of charge. Also good stuff. In pink, we have services which can be commissioned by health and social care providers, only works under commission. And in rainbow, somebody told me earlier on coloured slides were a sign of weak presentation. In Rainbow is stuff that can be provided by a branch or under commission or from head office or through grant funding. So if you said to me, what are you doing in Slough? I've got no idea, because it's really difficult keeping a track of all of this data. If I then try and apply it to your world, to work with you, it goes in my too difficult box. It's really hard. As well as being hard systemically, we're dealing at a personal level, all of us in this room and our mothers are dealing with a number of very complex individual dilemmas. And if any of you have seen this diagram before, it's based on Goldrat's cloud dilemma solving. I can tell you about this afterwards if you're interested. And we're going to read it from the right to the left. Sorry, left to the right. In order to be a good mother, I feel pressure to maintain public comfort. Don't want to stand out, don't want to be different, don't want anybody pointing at me. So I'm going to breastfeed in private. On the other hand, in order to be a good mother, it's really important to me that I live a normal life. I'm still normal. I need to breastfeed in public. And I can't do both. I'm either breastfeeding in private or I'm breastfeeding in public. From a societal point of view, those of you who are working in public health, focusing on societal health, in order to have a healthy society, we must reduce healthcare utilisation because we can't afford care for everybody. And in order to reduce healthcare utilisation, we'll medicalise breastfeeding. On the other hand, in order to have a healthy society, we need confident, empowered parents making good decisions for them. We've got to socialise breastfeeding. That's a real conflict with the healthcare professionals in the room. Really hard. And in order to provide the best support we can for our mothers, we must provide high-quality support as much and as often as frequently and wherever that individual mother wants it, which means we need to spend as much time as they need, not how much we've got in a booking an appointment or a GP practice clinic. On the other hand, in order to provide best support we can, we must provide a little bit of support to everybody, spend some time with everybody. It's not easy, is it? How we would tend to approach that with traditional integration models is we'll go and get lots and lots and lots and lots, have I laboured my point enough? Lots of data. We've got several UNICEF care pathways, particularly with the new Children's Centre one that's out recently. If you haven't seen it, it's worth a look at. We've got the NICE guidelines, we've got the map of medicine, the Atlas of Variation, my personal favourite. It shows you in a very graphic way what's going on. We've got the SPOT tool, we've got CHIMAT, we've got infant feeding surveys, and we've got continuous publishing. Public Health just issued a couple of weeks ago an update on what's happening with breastfeeding in London. It's a really good roundup of what's going on in breastfeeding if you haven't seen it. Lots of information. So where we seem to be, where the targets and the outcome frameworks seem to be pointing us, is our goal for the purposes of the next 5 minutes. Breastfeeding community support is working well. And what I mean by that is all mothers are breastfeeding for as long as they want to, not how long we think they should, how long they want to. And in order to achieve that, we've got 2 critical success factors that we're measured on. When I say we, third sector isn't, but most of you are. Mothers are initiating breastfeeding and mothers are sustaining breastfeeding. And we've got targets around those. I'm not meaning to be contentious, but I don't think that's enough. They are critical success factors, but if you start to think systemically, and when I say systemically, I mean all of us, something very interesting happens. So we're going to read down this, we're looking for necessity here. In order that all mothers are breastfeeding for as long as they wish to, we must have mothers sustaining breastfeeding. Yes? Yeah? Good. In order to be sustaining breastfeeding, they must have started breastfeeding. Great. In order to initiate breastfeeding, they have to hold an intention to breastfeed. And actually, most healthcare professionals kind of don't want to go there. But actually, you can go further. I'm liking you. We'll talk afterwards. In order to have an intention to breastfeed, Something else has got to happen. So if this is what's necessary, is doing what's necessary sufficient? So let's look at the sufficiency and we'll work it up the other way. Because our targets are based on the top two necessity objectives. It's gone in the too difficult box, look. So we're going to work it up the other way. Ignore the question mark at the bottom because that really is in my too difficult box for this presentation. Is it enough is what you're thinking. If, so not in order to, we must, which is how we read it coming down, we're going to read it going up, and it's not in order to, we must, it's if then. If mothers have an intention to breastfeed, then will they start breastfeeding? Well, we know they won't. We know from the evidence they don't. Some do. And if they're initiating breastfeeding, do they sustain breastfeeding? No. Again, we know from the evidence that they don't. Some do. And if they're sustaining breastfeeding, are they doing it for as long as they want to? Well, clearly we started there, so we've come in a great big, can I get the word right with a dry mouth, tautological loop. So, I know you won't be able to read that. It's not done that small so that you can't read it. Well, it kind of is because it's a work in progress and you might disagree. It's more to give you a shape of the map. If we map it as a sufficiency system, then we're then in a position to agree that sufficiency, and then we can focus on each one of those objectives and say, what evidence have we got? Not that we're doing it, we know we're all being as bright and shiny as we can be. What evidence have we got that we're not doing it? And we kind of end up with doing a bit of a Johari window on this. You kind of end up with a, what do we know we're not doing, and why are we not doing it? And let's be open and accountable for we're not doing it. We know, if I put my midwife hat on, I know I'm not doing it because I haven't got time. You know I'm not doing it because I haven't got time. So let's do something about that, shall we? So what do we know we're not doing because we haven't got time? What do we know we're not doing because we don't know how? What do we know we're not doing because actually I think the lady in red's doing it over in public health? Big assumption there because she might not be. What do we know we're doing? What do we know we're not doing? What don't we know we're doing? And if we can find that, we can sort this out. So using systems theory, there really can only be one constraint. If you imagine the weakest link, there can only be one weakest link. It will only break in one place. If we can identify the constraint in the system, and we all focused on the constraint, and if that means spending my budget instead of Philip's, that's okay, because we'll strengthen the whole system every time we strengthen a constraint. So, is this sufficient? In order for mothers to initiate breastfeeding, mothers must hold an intention to breastfeed. Yes. We know that's not sufficient. If they hold an intention to breastfeed and they're supported to overcome their inertia, and it's that whole ambivalence bit that I'm a little bit ambivalent to start with, so it's not going to take much for me to stop, and my immediate social network know how to and want to support me, and this is very mother-centred, it's deliberately not individual bits of the system, and mothers feel services are relevant to what they need, they trust them, they know about them, and clinical and other support, antenatal and during labour supports my breastfeeding, then is that enough for mothers to initiate breastfeeding? You could do a really nice consensus study on that. Well, I'm applying for grant funding for it, so watch this space. So, I've done this with that map you've just seen. I am doing a piece of action research on it, but I wanted to share these with you, and I do have permission to share them, but I'm not going to tell you where I was or who I was working with, but these are real quotes. We don't do that bit because we don't have time. Health do that bit. Actually, health don't, because I went and checked. We didn't know about it, so of course we didn't tell people to do it. We didn't know about it. Didn't know they were doing that over there. And this was my favourite. We're really, really good at that bit, but we don't know how to do it. Don't know how to do that bit. And it's kind of, if I can kind of get all those people in the room, we can actually design a system that works, rather than a system that I was asked to design last week when a different commissioner said to me, "So, Candy, if we put a single baby cafe, breastfeeding peer support social model, a single one, in our city, will you be responsible for our breastfeeding rates?" Clearly I said, yeah, obviously. I showed her the diagram. So, when it works, I'm going to read something to you and then I'm going to leave it there. Nothing's flashing at me, Philip, so I'm assuming I'm all right for time. So see if you can listen to these assumptions. This is not me, it's not a case study where I've done exactly that. This is just why we're doing it, why we're bothering, apart from, obviously, the economics. My name is Hanan Takal, age 35 and mother of 4. This is in her words. With my 4th child, the breastfeeding was not going well. After a couple of visits to the GP with no results or improvement, one of the doctors suggested Waldron Baby Cafe. This was my first ever time visiting a breastfeeding support group, and I thought it wasn't going to be any use to me. Well, I was wrong. I went there in pain, nearly in tears, only to find great support and help from the staff and the mothers. Just as an aside, this baby cafe is clinically led, as opposed to breastfeeding counsellor led. It's the various models that we do. That's important for you to know in a minute before you look at me in horror. I'm finally somewhere where people understand what I'm going through and know ways of helping me and my baby. After nearly 8 weeks of suffering and nearly giving up breastfeeding, I was supported to get the right treatment for thrush and a referral for the tongue tie clipping surgery, which was easy and straightforward. What a relief! Finally, everything I was going through made sense and could be treated. My baby is now 6 months old and I am still joyfully breastfeeding. Thank you for your help. How good's that? Wouldn't that be good for every mother? Isn't that what we're trying to do? I think so. Thank you.